and we are all doing this modality since last 3 to 5 years. So this is the journey of mine with Dr. Nidhi Bhatnagar. That's what I wanted to share here.
Thank you so much.
Thank you so much. It's very inspiring to feel, but if I am there to extend what I know, and if there is nobody to receive, it's no good. So I'm grateful to all the radiologists I have come in contact with who showed keen interest and contributed to the growth of this modality. It's just not me alone. It cannot be just one person. It has to be a continuous effort with a group of people who feel and are like-minded. So thank you very much, Rahul, Roli, for making this work. I'm glad. I'm very happy that it worked well for all of us.
Man,
Thank
you are the really inspiring person behind us. We started with you and still now we learn a lot from you. Really speaking, MSK is one of the modalities, ultrasound, that it's a boom in the field of ultrasound. Because really a spotter, you put the probe, you give the answer many times. In 2 minutes, it's really a smile on the patient's face that at least the diagnosis is made.
Yeah, and we try very hard not to smile.
Madam, Dr. Ratnafarki sir is the one of the interventional cardiologists who does highest number of angioplasties in Mumbai.
Lucky.
And he has such a good network among all the doctors and always happy to help to the junior doctors to grow their practice and always ready for any help in Mumbai.
That's
So
very inspiring.
Rahul, thank you for nice word, but I want to say that Rahul is the most enthusiastic person. Roli will definitely say yes, because so many times we gathered at his home for singing, for dancing, for other parties. Okay, so much enthusiasm he brings. I don't know kahan se lata hai.
sir, I will say Dr. John.
Yeah, I'm coming to him. You have intense. I mean, Dhyanachi book mantra, sort of go on learning. Always go on learning something. Okay, you not only learn from the books, from the persons itself.
I agree.
And now today you got a great combination with Dr. George, Dr. John Rodriguez. I mean, I know both of you last 20 years. John, I don't know more than 25 years. Okay, I mean, John is also so enthusiastic, and you just name the field, you'll find his active presence there. He's a musician, he's a guitarist, he teaches guitars to so many doctors.
Wow.
He's a marathon runner, he's an athlete, not only an excellent homeopathic physician, he's a very gentle, thorough gentleman, I mean, with a huge heart. I mean, this is a very dreadful combination of John and Dr. Rahul. ये दोनों साथ में आए ना, is absolutely गंगा जमुना का sort of संगम बोल सकते हैं.
Sir, Rahul never misses opportunities, huh? He always keeps good people around him.
Okay. And another thing from Rahul is from my town basically. Okay, I know his mama, chacha. Okay, from Amravati. Okay, so हमारा गांव का product है वो.
Sir, you are very inspiring. I said to Praveen, cardiologist हो तो ऐसा. I said to my husband, kitna lively, very inspiring in work, in a living life. Hats off to you. They say that.
Yeah,
and Deepak sir, we are always inspired by you. It's like always hearing your name is a... Yes, sir, always inspired by you, was in Nanavati, always just wanted to have a glimpse of you, meet you, and like, wow, what a work, really.
Dr. Bhatnagar, it would be very nice for me to know one day that you have gone on a hike or you have gone on a cycling spree like Rahul does. I don't know ever if you relax. You're constantly on the go, constantly.
I'm cycling all the time.
You are? Okay.
Working.
You got to post some pics on your Facebook. I'm not going to believe you otherwise. And kudos to your wife for standing by you all the way.
Here she is.
Oh, she is? Let me say hi to her.
Hi.
Hi, ma'am. This is Dr. Nidhi. Hi.
Hi.
And you've got to know how much I am in awe of Dr. Deepak Bhatnagar, but I'm more in awe of you. Really. I'm
Thank you so
hats
much.
off
Thank
to
you so
you
much. Thank
for
you.
being right by his side. And I know he works very hard, but aapko bhi gussa aata hoga, but you must be.
I'm beyond that now.
You are? I got to come and learn some tips from you then.
Most welcome. Most welcome.
Congratulations for making an awesome team.
Thank
An awesome team.
Thank you.
Great. Take care, ma'am. Stay safe.
One thing regarding Dr. Deepak Bhatnagar, sir. I mean, he's such a huge personality. He's a big person, but still he's so down to earth.
Absolutely.
And he's so approachable. I mean, anybody can go and meet him. And he's holding post of a medical director. Approachable. Anybody, anytime can.
चलो ये बंद करो प्रोग्राम चालू करो.
Yeah, sir.
Sir, I know you from PS days, sir, from 94, 95. Rahul, Dr. Bhatnagar and I was together in PH Medical. I mean, I can proudly say that.
Okay.
1995 or 96.
True.
Bhatnagar sir is always the problem solving for all the radiologists, I think, across the India. Whatever the problem comes, we just, at least in Mumbai, whatever the problem regarding any machine, regarding anything, we just call Dr. Bhatnagar sir, aap jara baat karo na please. And the problem gets rectified. Yeah, Dr.
Yeah.
John, let's start.
Yeah, now see, we have come to 54 participants with permission of Dr. Ratnapaki sir and Dr. Rahul Saoji. Should we start or should we wait?
Yeah, I think we already crossed 50 and it's 6.
Yeah, 54. Yeah, almost coming to 55. Yeah, people will keep joining us. Dr. Rahul, are you ready?
Yeah, I'm ready, sir. I'm
Yeah.
ready.
Yeah, first, thank you, participant, and especially a big thank you to Dr. G.P. Ratnapaki sir for your kind words. I think without Dr. G.P. Ratnapaki, nothing was possible. He is one person. He has brought all the doctors of Mumbai together. If Dr. Rahul is here and if I am here, Andheri Medical is here, Parna Medical is here, I think it is the Fevicol Jod of Dr. Ratnapaki sir. Thank you so much for being the binding force, the inspiration behind all of us. Okay, welcome participants. Today is the 65th webinar, which I have been conducting for the last 1 year of lockdown. I started within 15 days of lockdown last year. We had a lockdown announced on 24th March 2020. Our first national webinar was conducted on 4th of April, just a matter of 10 days. And in the last 1 year, this is the 65th National Doctors Webinar on different topics, which will help doctors to become better physician practitioners to help COVID as well as non-COVID. So in our initiative, we have brought around the part of radiology, and we have wonderful speaker, Dr. Rahul Saoji, a good friend of mine, who will be sharing his experiences today. But before we start, I want to introduce Dr. G.P. Ratnapaki sir, a most eminent, the most, what is called a successful cardiologist in India, and who has been in the maximum amount of angioplasty, always ready to help. He's here today to introduce the guest of honor, Dr. Deepak Bhatnagar. Over to you, Dr. G.P. Ratnapaki sir.
Thanks, Dr. John, for your nice word. Thanks, Dr. Rahul, for allowed me to sneak in this meeting of giants. And it's my honor to introduce the great, I'm coming to Innovative, the great friend of mine, Dr. Deepak Bhatnagar sir. He is in the practice, radiology practice, last more than 33 years. Right now, he's also in the department of in Nanavati Hospital, and also the medical director of Nanavati Hospital, where we are working under him. He's a past chairman of Indian College of Radiology and Imaging. He is a member of National Steering Committee of Indigenous MRI. He was chairman of Scientific Committee of Asian Congress of Radiology in 2018. He received an award that Best Teacher in Radiology in 2019. Rather, I should say he should have received a Teacher of the Teachers Award because he has number of papers under his belt. He has published more than 150 papers in Indian radiology journals and more than 75 papers in international radiology journals. He delivered lectures more than 1,500 like that. And he's a teacher for the DNB. Such a huge person, but so down to earth. Anybody can approach him anytime. Sir, thank you very much for joining this webinar. Dr. John, hand over to you.
Yeah, thank you so much, sir. I request Dr. Deepak to introduce the speaker of the day.
Thank you, Dr. John. Thank you, Dr. Ratnaparki, for kind introduction. I have known Rahul for almost 2 decades. I must thank him for thinking about me for felicitation. I also thank Dr. Nidhi, Dr. Roli for being part of this 65th seminar. As I said, I've known Rahul for almost 2 decades now. He is a very, very astute, friendly, and academic radiologist. Always hungry to learn everything that is new in radiology, learning new facets of radiology all the time. And he makes it a point to find ways to spread the knowledge, not only across the medical fraternity, but across the entire population in and around the area of his practice, in spite of his very, very busy schedule. And this is very, very innovative way of doing what he is doing in these difficult times. Musculoskeletal radiology, like any other field in radiology, has always been a very, very popular subspecialty, which allows the orthopedicians and sports medicine specialists to detect pathologies very, very accurately and treat them quickly. Because for this, time is very, very important. Most of these personalities that require this field of radiology would be professional, practicing athletes, and injury hampers their earnings. Nidhi, as Rahul has been saying, has done a great job in spreading the knowledge of ultrasound-related musculoskeletal radiology across the country and beyond that. Managing musculoskeletal disorders is very, very important, and Rahul has gained this knowledge over last decade or so and spreading it across our friends. Ultrasound is a very versatile and affording modality in detecting many of the disorders which may not require MRI. Also, you can repeat it several times. A lot of my friends and students have learned how to use musculoskeletal ultrasound in treating these patients as well. So painkillers, steroids can be given at the site of pain for instant relief. Also, certain chronic disorders can be taken care of by using USG MSK radiology to treat chronic pains, aspiration of ganglia, injection in rotator cuff, knee joints, hip joints, etc. We as radiologists need to acquaint ourselves to this versatile modality and understand the nuances. Dr. Rahul and Nidhi will do this in next 1.5 hours or so. They have learned their skills by going through the difficult drills that any radiologist who's practicing has to do to acquire new facets of radiology. We all know radiology is a very, very fast changing field of medicine. As I said before, I have known Nidhi for last 2 decades or so, and we have traveled together across the country teaching. Hope all of us get through these difficult times safely and see each other in person as quickly as possible. And I'm an ever optimistic. As Martin Luther King said, we must accept the finite disappointments, but never lose the infinite hope. Thank you all once again for having me here, and enjoy the academic feat this Sunday evening. Thank you.
Thank you, sir.
Yeah, thank you, Dr. Deepak Patkar, sir. And Dr. Rahul Saoji, you can start your presentation.
Before presentation, I would like to welcome Dr. Nidhi Bhatnagar and introduce her to all the viewers that she is the one radiologist who really don't need any introduction in the field of radiology. So the madam is the head of the department at Max Hospital, New Delhi, and I will say she is a pioneer of musculoskeletal ultrasound in India, and she's an excellent radiologist. Thank you very much, Nidhi madam, for joining us. Our another special invite is Dr. Roli Chaudhary. She works in Ambani Hospital, Kokilaben Dhirubhai Ambani Hospital, Mumbai, and she is one of the finest musculoskeletal ultrasound specialists in India. And thank you very much, Roli, for joining us. And that's it about the thing. I can start. Madam, if you want to have just few words about this thing, you can just share.
I'm very happy to be here. Thank you very much, Dr. John, Dr. Ratnaparthi. Thank you, Rahul, for having me here. And I very keenly await to hear your presentation. Please go right ahead. Thank you very much.
Thank you so much, Dr. Nidhi, for being with us. Dr. Rahul, you have come to, 90 participants are almost in, always eagerly waiting for you. Dr. Roli wants to say something before Dr. Rahul starts. Okay, you can start, Dr. Rahul.
Thanks, Dr. Rahul, and all the organizers for inviting me here. We started, Dr. Rahul and me started our journey in 2015 for musculoskeletal ultrasound. And now we are here. And I believe musculoskeletal ultrasound is one of the finest modality where we can image soft tissues with higher spatial resolution. And it has really benefited a lot of my patients over the 6 years. Rahul is a very fine MSK ultrasound specialist, is now going to deliver the lecture. Thank you once again. Yeah.
Thank you. So we'll move to the presentation now.
Yeah, Dr. Rahul, 1 minute. We are coming to the full of almost 90 plus. So all those who come after 100, I will be putting on Facebook Live. So I'll be passing on the link. So if anyone who's not able to enter after 100 can come through Facebook Live streaming. I'll be sending the link. Thank you so much.
So shall we start?
Yes, you can start.
Okay, good evening, everyone. Now, today's topic of discussion is understanding radiology in medical practice. I will be covering X-ray and sonography here. So let's start today's session. First, we will cover X-ray and then we will move on to the sonography. So among all the X-rays, chest X-ray is the most commonly advised in clinical practice. And what is the motto of this teaching session is that you all practitioners send patient for X-ray and radiologists remove X-ray, give the report. When patient comes to you I want all the clinicians should understand what exactly radiologist has pointed out in X-ray. So I will take my lecture from basic chest X-ray reading. We all have learned chest X-ray in our medical practice, but in due course of time, we really just more and more practitioners are dependent on the reports. So this session is just to brush up the knowledge and update all of you people here. So let's understand chest X-ray. So this is the chest X-ray. Now, whenever we advised X-ray, we always write chest X-ray PA view or chest X-ray AP view. So what is a PA view? That is a posterior-anterior view. Here I am showing you how we remove the chest X-ray. See, you can see the patient and this is the X-ray tube. So X-ray tube, X-ray beam is coming from posterior to the anterior. So this is chest PA view. And everything has its significance. When to describe chest PA view, when to prescribe.
Rahul, unmute. You're gone muted, Dr. Rahul.
Yeah, no. Am I audible?
Yeah, better.
Okay. Sorry for that. So here I will repeat. So here I have shown you these two pictures where I'm trying to show you how we remove chest X-ray PA view and how we remove a chest X-ray AP view. So we always keep a 6 feet of distance between the X-ray cassette and the X-ray tube, because if this distance is less, then there will be a magnification of a hard shadow on a chest X-ray. So this distance should always be precise of 6 feet. So now this is a normal chest. This is the normal chest X-ray. Here I will show you all how to read a normal chest X-ray. There are two methods. Either you can go from outside to inside or from inside to outside. It is always better to start from outside and go inside. So what I mean by that? So outside is soft tissue, bones. So first have a look to the soft tissue. So have a look towards this soft tissue. Is there any axillary lymph nodes? Look to the bones about the clavicles. And I would like to tell you the X-ray film should be properly positioned and properly exposed. So normal chest, in a normal good exposed chest X-ray, you should not see more than 4 to 5 vertebrae. If you see all the vertebrae on the chest X-ray, that means the film is overexposed. And see, you can see the spines here. These two clavicles, this is one end of the clavicle, this is another end of the clavicles. These two clavicles should be equidistant from this spinous process. If one of the clavicle is far away, that means this X-ray is rotated. And in that case, again, you may missed or you may overdiagnose the things. So it should be properly positioned. It should be properly exposed, because if the X-ray film is overexposed, that means if you see all the vertebrae here and the both lung fields are more black.
Request the participants to kindly mute.
નહીં છે હમણાં મૂક્યા કઈ છે કયા શેમાં મૂકે બીજું બોક્સ છે આનું
Okay, you can continue.
So it's okay. So if you see both these lungs are more black, if you see the vertebra, all the vertebrae are seen, that means the X-ray film is overexposed. And overexposed X-ray film can hide the faint opacities of the lung, like a pulmonary cox. Pulmonary cox opacities are very soft opacities. the X-ray film should not be overexposed. If it is an overexposed film, sometimes the soft opacities, early opacities can be missed. So if a radiologist given you the report that no opacity is seen, and if you can see this is a highly overexposed film, not a good quality X-rays, just talk to the radiologist. Sir, just talk to the radiologist and ask him to repeat the X-ray. So I want you all to see this as a clinician whenever the X-ray comes to you. And once you look at the soft tissues, then look at the clavicle. Sometimes unknowingly we miss the clavicle fractures on a chest X-ray. Then move on to the rib cage. Because you are a clinician, you know better where is the patient's pain. Sometimes you just ask chest X-ray for the pain in the left lateral region or right lateral region. So have a look to the ribs and then see to the lungs. So this is the left lung, this is the right lung. So again, how to come to a conclusion which
Dr.
Am I
Rahul,
audible?
we cannot hear you. Now we are audible.
Am I audible?
Better.
Yes, yes.
Dr. Nisha Shah, who is helping us with the.
Oh,
Thank you,
sorry,
Doctor. Dr. Nisha, thank you so much.
Yes, sir.
Yeah, Dr. Rahul, you can continue.
Okay. Okay. Compare these two lungs always and see whether this radiolucency, that means the blackness of the lungs are equal on both sides or not. If there is some unequivalency in both the lungs, then you can think of an infective process in that lung. So I was talking to you about how to confirm whether which side is the left and which side is the right. So always radiologists make right mark, but you also should know always the stomach bubble, this is the stomach bubble, that is the gas in the stomach, is on the left side because stomach is on the left side. So this lung is the left lung because the stomach bubble is on the left side. So always see that. And normally this heart shadow, 2/3 of the heart is on the left side of the chest and 1/3 is on the right side of the chest. So this stomach bubble is on the left side, most of the heart is on the left side. So this is the left lung and this one is the right lung. Okay. So once you confirm all these things, once you see the lungs, then come to the hilum. So hilum is this area, this area. This is on right side, this is on left side. What is this structures we are seeing here is the pulmonary arteries. Okay. So this is normal looking hilum. So there are pathologies where you can see the hilar fullness that I will show in our next slides. This is the trachea you can see here. This is the dividing trachea. This is the carina. This is the main right bronchus. This is the left main bronchus. And this one is the aortic knuckle, aorta. This is the aorta. Aortic knuckle is always seen on the left side of the chest. So I will repeat. So normally chest PA view, we see, look for the lung parenchymal abnormalities. AP view, we ask whenever we are suspecting bony abnormalities. These ribs are better seen in AP view. So if you are suspecting a rib fracture, ask for an AP view. And when you want to see the lungs, heart, always ask for the chest PA view. Okay. So this is the next slide. I'm just summarizing. I have labeled it. whatever I have spoken just now in the last slide, this is the trachea, this is the right main bronchus, this is the aortic arch, these are the pulmonary arteries. This is the left ventricle, this is the diaphragm, this is the right side diaphragm, and below the right side diaphragm is the liver, and below left side diaphragm is the stomach. Hope I'm audible and the slides you can see well.
Yes, Dr. Rahul, one announcement. We have reached maximum 100 capacity. So I have put on this Facebook link. So just kindly forward that Facebook link to all participants in the waiting room. They can see you Facebook live. Dr. Nisha, can you do the needful? Put it on all the groups.
Yes, I'm doing it.
Yeah, Dr. Rahul, you can continue.
Okay. So the common pathologies, what we see on chest X-ray, there are the infective processes, pleural effusion, cardiomegaly, hilar lymphadenopathy, then rib fractures and mass lesions. So now this is the first abnormal X-ray I'm showing you all. So when the X-ray is in front of you, you have to see the soft tissues, you have to see the clavicle, you have to see the ribs, then come to the lungs. Here this X-ray, compare, I told you compare two lungs. So compare this lung, right lung with the left lung. So in right lung, you can see the lung is black, the lung is black, and on the same, this is the upper zone of the left lung, and you compare this upper zone of the right lung. Here you are seeing the opacity, and along with opacity, you can see this round ring-like structure. So that is the cavity, and this is the opacity. So in pulmonary tuberculosis, the opacity is more common in the left upper and mid zones and along with the cavity. So this X-ray radiologist will definitely report as a pulmonary cox infiltrates with cavity at left upper zone and likely to be tuberculosis, pulmonary cox. So this is the infective etiology which we commonly seen in our routine day-to-day practice. So here I am showing you another X-ray. The same thing, you compare two lungs, okay? And what you are seeing here is this triangular shape opacity in the right mid zone, okay? This is the opacity here. But in our last slide, what we had seen is the cavity. Here we are not seeing any cavity. In fact, we are seeing this is the triangular shape opacity, which is limited by the lobe of the upper lobe. And usually you can see this small black, that is, we say the hypodensities in this opacity. That is the air bronchogram. And air bronchogram is the classical picture of a community acquired pneumonia. So the diagnosis was consolidation in that previous one. So now this X-ray. Now you see here, this is the right lung, this is the left lung. I'm sorry I have not mentioned about the Costophrenic angle in our normal chest X-ray reading. This is called a Costophrenic angle, where this is the angle between the diaphragm and the ribs, called Costophrenic angle. This should be always sharp. If that angle is obliterated, that means if the angle is not sharp, you always should think of some sort of a pathology there. Here you can see this angle on right hand side, it's sharp. This is soft tissue shadow. This is not a pathology. But on left hand side, you can see this opacity which is obscuring the right left costophrenic angle. And you can see this crescent shape thing that is more classical of a pleural effusion. So on this chest X-ray, your diagnosis is pleural effusion on left side. Okay. Hope you guys are able to understand what I'm talking. Yeah.
Yes, very clear. You can go forward.
Okay. So now this X, see what we are seeing here. We are seeing the costophrenic angles are clear. See, this is the right costophrenic angle. This is the left costophrenic angle. See the lungs. Both lungs are equal in translucency. That means both lungs are equally black. There is no opacity as such in the lungs. You can see this trachea is in the midline. Normally it should be in the midline. It should not be on one-sided. If it is on one-sided, that means there is some force which is just pulling it on that side. What we are seeing here, look, this heart. This heart is not of a normal size. I will show you how to measure the heart size in my next slide. But this heart is definitely not looking normal. So this is the case of a cardiomegaly. In my next slide, I will show you all how to measure the cardiac size. See, and this is a normal size of the heart. How we comment that this heart is of normal size and not cardiomegaly? See, this is the central line, imaginary line on the spine. You measure the left side heart of the heart, you measure right side of the heart, make them, add both of them, and then you measure the distance between this rib, right side of the rib, and the left side of the rib. This distance, this ratio should be less than 0.55. Then we can say it as a normal size heart. If it is more than that, then it's a cardiomegaly. So in our last slide here, this is definitely, this whole distance is more than the 0.55 of this distance. So we are considering this as a cardiomegaly. On chest X-ray, you can comment on which chamber of the heart is enlarged, definitely. But that is beyond the scope of this lecture. You can, normally this side is the left ventricle and this side is the right atrium. Okay. So you all know there are specific reasons for left ventricular enlargement, commonly hypertension, cardiomyopathies, and the left atrial enlargement, more common is the mitral valve disease. But that is very vast. We'll not cover this in this. I'm just showing you the basic, what is the basic knowledge one clinician should have when X-ray comes to you or when you are prescribing for the X-ray. So now, here in this X-ray, you can see the lungs are clear. You can see the costophrenic angles are clear. You can see the heart size is normal. But what is striking here? The striking here is the hilar. See, you can see this hilum, it is really bulging. This hilum is also fullness. So the problem is in the hilar. I will show. So most common pathology which causes fullness of the hilum is the hilar lymphadenopathy. This is the same pathology. This is the hilar fullness. See, this is here you can see more of a globular thing, rounded thing. That's the hilar lymph node. Okay. So on chest X-ray, when you see this fullness of the hilum or this sort of a bulging at the hilum, then we consider it as a hilar lymphadenopathy. Normal hilar, they have a hilum like a pointed, hilar point we say. See, this is the hilar point. And here that hilar point is lost. You can see the bulging here. Understand? See the bulge. That pointing is lost and the bulge is there. So that is a hilar lymphadenopathy. Now this X-ray, what we are seeing here. So our habit of comparing both the lungs will show the importance here. You start looking at the X-ray and see what is striking to your eyes. See, this is the left lung, this is the right lung. Okay, though it is the labeling is not there, but we can see most of the heart is on this side. So this is the left heart. Here the marking is there. Here also you can see, this is another two different X-rays. Yeah. So here you can see this left lung, and here you can see this left lung, and this is the compressed left lung. This is whole high black thing you can see here. Radiolucency you can see here. So on chest X-ray, anything black is air, because our lung contains air and lungs are black. So this is air and fluid is white. Okay, radio opaque, and black is radiolucent. So this is the pneumothorax, and this air in the pleural cavity is compressing the lungs so much. And here you can see the compressed lung. Okay, so this now
and make out small it is.
This X-ray is oblique X-ray for the ribs. For ribs, to see the ribs better, we should ask for the oblique X-ray, AP X-ray and oblique X-ray. So many times you don't see any rib fracture on AP X-ray as well, but it can be picked up on the oblique X-rays. In this X-ray, you can see very clearly.
So you are
this
not
rib
audible.
fractured. I'm not audible? Am I audible?
You're audible to us.
Yes, yes. You are audible.
Maybe check your Wi-Fi. The one who's complaining, maybe your Wi-Fi is weak. Just check your Wi-Fi.
Okay, okay.
Yeah, continue, doctor.
Okay, so this is the oblique X-ray of the ribs. So always remember, whenever you are suspecting rib fracture, patient had a trauma, and you are asking for an X-ray, don't write X-ray chest PA view. Always write X-ray chest AP and oblique view. Why AP and oblique both? Because in oblique view, you can see the fractures, and in AP view, if there is any time a pneumothorax, and because of the fracture rib, and if it is compressing the lungs, you can see it on AP view. But if the affordability is a question, then ask for an oblique view. Wherever the trauma on right side or left side, ask oblique view of that side. If you ask for PA view, radiologist will write sometimes normal, and then you'll feel, X-ray mein kuch nahi aaya. But the fault is not of a radiologist. It's a referring doctor who should ask for the correct views. Yes, radiologist has a duty to see the patient, but so many times it is not possible in practical setting. Reception see the prescription, and whatever the X-ray is written, technician remove the X-ray and radiologist report. And in so many setups nowadays, the tele-reporting is there. So radiologist at different place, X-ray is at different place taken. So in that case, fracture rib can be missed. So always keep in mind, always ask for an oblique view whenever you want to see fracture ribs, when you want to rule out fracture ribs. Now here, this is the ring in this left lung. So this is very obvious. This is a mass lesion. Here you can see this opacity is very much, looks like a consolidation or a spreaded one. So there the history plays very important role. So as a clinician, always write down the history, whatever is the history of weight loss, persistent cough since last 1 month or 2 months, and maybe hemoptysis, because all these things give clue to the radiologist to come to a conclusion. Otherwise, this X-ray, you can easily say this might be the infective process. But such a large X-ray, of course, we had a follow-up of this patient. We did a chest CT scan and it was a bronchogenic carcinoma. So I'm just trying to show you how bronchogenic carcinoma looks like on X-ray. So here again, the rounded mass, which is very much close to the hilum. That means it is for the bronchus, maybe the segmental bronchus is involved here. So this is how the carcinoma bronchus looks on a chest X-ray. So now here I am showing you some picture of the COVID lungs. I will again say in COVID, CT scan is the diagnostic modality. Don't ask for X-ray in the mild COVID cases because X-ray may be normal. Because in COVID, there is alveolitis first. An alveolitis on X-ray will be looked as a normal, and CT scan it will be a diagnostic. But still, I am showing you some patterns of COVID X-ray, COVID chest. See here in this first X-ray, you can see subtle opacity, just a prominent vascular markings. Sometimes you may see just a non-specific findings. But with the correct clinical history, you can come to a conclusion. This is more than a mild disease. So you can see this peripheral opacities here. Peripheral opacities are the hallmark of COVID disease. The same X-ray, you can see these opacities, peripheral opacities. Can you see the peripheral opacities? Yes. Here again, the peripheral opacities. So this is the case. These are the COVID lungs. And see the chest X-ray. This is the CT scan of the chest. This is the CT scan of a chest. I'm sure that this is a mild disease. You can see some sort of a soft alveolar opacities in the peripheral lungs. This is how the normal lungs looks like. These white things are the vessels, and this is the lung. These are the pulmonary arteries, basically. And this is the soft opacities. This must be a mild disease. Here you can see the both lungs are flooded with the opacities. Must be a moderate COVID. Here you can see the thick opacities in between these opacities. This is moderate to severe COVID. This is definitely a severe COVID. So this is how this COVID opacities looks on CT scan. So to summarize, when you look for a chest X-ray, look for the from outside to inside. So these are the soft tissues. This is the clavicle. This is the trachea. This is the aorta. These are the pulmonary vessels. This is the carina. That is the bifurcation of the trachea. This is the carina. Okay. Now, this is the gas under the dome of diaphragm. So this is the stomach. These are the Costophrenic angles. And these are the lungs. So it is a left atrium showing. So this is how you should approach to the normal chest X-ray. Hope I'm able to explain you and you all are understanding what I'm trying to say you.
Yes, right? Dr. Rahul, very clear.
Yes, yes.
Thank you, thank you. So with this, we will move to the emergency X-ray. So I have emergency X-rays are like these X-rays. Here, this is the X-ray abdomen and chest in an erect position of a child. Okay, because you can see here these epiphyses are not fused. So this is definitely a child, and in one film we can see the whole things here. And what is the abnormality we are seeing here? Abnormality here is this is the foreign body. So this is the metallic foreign body. That's why we are seeing it on the X-ray. This X-ray typically comes in an emergency to you to look for where is the foreign body, whether it's in the trachea, whether it's in the abdomen, and where is that. So more probably this is in the transverse colon. Of course, we need a lateral X-ray for that. Yes, the second emergency X-ray comes is that pain in abdomen and vomiting. So what we are seeing here, whenever the patient comes to you with abdominal pain, rigid abdomen, gardening there, vomiting is there, always ask for X-ray abdomen standing position. Why? We have two things in mind. One is the perforation, second is the intestinal obstruction. That we can see very clearly on X-ray. Sonography will rule out other causes of pain in abdomen like renal colic, gallbladder colic, liver abscess, appendicitis. But sometimes intestinal obstruction, yes, can be picked up on sonography, but X-ray will just point the diagnosis. What we are seeing here, this is the small bowel loop are so much of distended with air fluid levels. What is meant by air fluid levels? See, this is black is the air and this is the fluid. See, this is the fluid, white is the fluid, black is the air. See, this multiple air fluid levels we are seeing along with the dilatation of the small bowel. So that's the intestinal obstruction. Here you can see the hugely dilated bowels with gaseous distension, and definitely this is the intestinal obstruction. So now this X-ray here, this is how the normal gas pattern look on X-ray. We are seeing the gaseous distended bowel loops, but we are not seeing the air fluid levels. So what is the abnormality in this X-ray? This is the normal fundal gas, okay? But this black, this is not normal. This is the right diaphragm, and there should not be a gas under the dome of diaphragm on right side. If you see this gas under the dome of diaphragm, this is the classical picture of intestinal perforation. And this is really a dead emergency. Immediately patient should be shifted to the hospital and surgical intervention should be done. Okay. So always remember there should not be gas on the right side of the abdomen under the dome of diaphragm. So with this, we will move to the sonography. I think we have enough time. I think we are in time, Dr. John. Dr. John?
Yeah, we have time. You have another half an hour.
Okay. Okay. So now we'll move to the sonography in routine medical practice. Okay. What are the common indications? Common indications are pain in abdomen, pregnancy, and to rule out a neoplastic process. Here I am focusing more on an obstetric pregnancy ultrasound. And the reason being is that routinely we are seeing so many of references, but the referring doctor don't write the correct sonography which has to be done, and that's the reason patients suffer. Patient lost the money as well and not the properly within the sonography. So I'm focusing on pregnancy sonography. So the indications are basically between 6 and 8 weeks. First, we should ask for a sonography to confirm whether it is the intrauterine pregnancy or not. Pregnancy can be intrauterine or ectopic. Then the another indication is to confirm number of pregnancy, whether it's a single, multiple, triplet. Third is for the viability, to know the cardiac activity, so that we know this pregnancy is viable. And is there any associated uterine abnormality, like abnormal shape of the uterus, that is a bicoordinate uterus or a septate uterus, sometimes the fibroids. All these abnormalities we can see between 6 to 8 weeks. So first sonography you should prescribe as soon as the lady missed period after, and lady missed the period. After that 1 week of time you prescribe for a sonography. And here I would like to tell you the first sonography is always a transvaginal sonography, because on transabdominal sonographies we cannot see the cardiac activity in early pregnancies, and uterine abnormalities we can miss on transabdominal sonography. So prepare your patients for transvaginal sonography. Tell them doctor will do the sonography through vagina, transvaginal sonography. Because we have seen so many times someone say heartbeat is not there because they had not done the transvaginal sonography. And when we do transvaginal sonography, we can see the heartbeat so clearly. Even sometimes you can miss the twin pregnancy on transabdominal sonography if the bladder is too much of full. So the first sonography is always at 6 to 8 weeks and transvaginal. Second sonography is at 11 to 14 weeks. It's very important sonography. That is we call nuchal scan. Nuchal scan is for to rule out any aneuploidy there. Basically, it's a Down syndrome screening. Okay, and it has to be done in a precise period. We say it is between 11 to 14 weeks. Okay, if it is less than 11 weeks, we don't do it. And if it is more than 14 weeks, we also don't do it. So this sonography should be between 11 and 14 weeks. So many times we see paper of nuchal scan at 16 weeks, 15 weeks. So that patient is not in fault. It's the referring doctor who should have knowledge when to send for a nuchal scan. Because nuchal scan, they have such specific criteria set all over the world. And we just follow those criteria and do the scan. I will come to that in my previous and in next slides. Then third sonography is between 18 to 20 weeks. That is the anomaly scan. You all are aware about the anomaly scan. I will go in detail what will look in anomaly scan generally. Then the fourth sonography is at 24 to 25 weeks. That is the fetal echo. What is fetal echo? Fetal echo, we see the baby's heart in detail. So you will ask, don't you see the heart in detail whenever you do sonography? I will say, yes, we always try to look carefully to the heart, but at 20 weeks, we really can't see heart in a very good, its heart is very small. Sometimes we can miss small VSDs or rare congenital abnormalities at 20 weeks. So we do fetal echo, that is the heart scan at 24-25 weeks. Then the next sonography to look for the growth of the baby. That should be with color Doppler. And why color Doppler? To detect early PIH, pregnancy-induced hypertension, or to diagnose IUGR, early IUGR, intrauterine growth retardation. And the last sonography at 34 weeks. So that's the color Doppler test. Here we'll look along with the baby's position, baby's weight, baby's fluid around the baby, that is the liquor, os condition, cervical length. We see the obstetric Doppler fetoplacental circulation. Why it is important? Because there can be chances of late onset IUGR. And if that late onset IUGR is missed, then sometimes there can be IUFD, intrauterine fetal death. Suddenly patient will come to you with no movements and you will be surprised. 7th month tak to sab theek tha, ekdam se kya ho gaya? So it is that IUGR, late onset IUGR, which was there. So this is the routine protocol. So don't worry, nowadays we give the chart along with the patient sonography report when she has to come for the next time. Just go through that chart and ask your patient. You don't miss the date of nuchal scan and anomaly scan, because in India, you cannot go medical termination after 22 weeks of time, after 20 weeks of time mostly. So if they miss the anomaly scan and you send them at 24 weeks, and if there is a severe anomaly, grave anomaly, then that lady has to carry that fetus till the full time and she cannot do the abortion. So don't miss anomaly scan time and nuchal scan time. So this is how the first 6 to 8 week sonography looks like. Initially, see, this is the normal intrauterine pregnancy. You can see the gestational sac. Gestational sac is this thing, big ring. Inside it is the yolk sac and the embryo. So this is the embryo here and this is the yolk sac. This is how we see it at 6 to 8 week scan. And this is transvaginal. Here, this is the ectopic pregnancy. See here, this is the uterus. We are not seeing this gestational sac in the uterus, but gestational sac is there outside the uterus. So we have confirmed that there is a ectopic pregnancy. And this is the importance of doing sonography between 6 and 8 weeks of time. So as I said, the indication of 6 and 8 weeks sonography is to confirm the numbers, whether it's a single or twins. This is a twins pregnancy. This is the basically a 3D image, and this is 2D image. So this is a twin pregnancy. You can see these 2 gestational sacs with 2 yolk sacs. So this is a diamniotic, dichorionic twin, intrauterine twin pregnancy. You can confirm the viability at the same time. You can confirm whether it's a monochorionic. That means whether there is a single gestational sac, then it is a monochorionic. If there is a single yolk sac, then it is a monoamniotic. So in detail, I will not go. I will just show you all how the early pregnancy images looks like. Actual pregnancy sonography images looks like. So this is around 8 weeks, 8 to 9 weeks, I will say. And here, this is a 4D ultrasound of a twin pregnancy. You can see these 2 babies very clearly, 2 fetuses in a different compartment very clearly. See, you can see these legs and hands and see the face. Okay. So sometimes we use 4D in early pregnancy, basically in a multiple pregnancies. Now this is 11 to 14 weeks nuchal scan. Okay. How this is there worldwide, the image is same. Whenever the radiologists do nuchal scan, any radiologist or a gynecologist sitting anywhere in the world can see whether he has done it properly or not, because there are specific criteria, and that's why nuchal scan took a lot of time. There should not be hyperflexion or extension of the neck. See, this is the neck. Then it should be in a mid-sagittal portion. You should be able to see the nasal bone. You should be able to see the space between the mandible and the chest wall. The zoom should be perfect. You should not see entire body of the baby. And where is the nuchal thickness we measure? Nuchal thickness we measure is the posterior neck thickness. There are criteria to measure this thickness as well. That is for the radiologist, how we should measure the nuchal thickness. But this is for you all. I'm showing you here, I have measured the nuchal thickness. This is the nasal bone. So basically in nuchal scan, we see 4 things. One is the nasal bone. Absence of a nasal bone is a marker for Down syndrome. Then second thing is the nuchal thickness. Increased nuchal thickness is diagnostic of aneuploidy, commonly the Down syndrome. Then third thing we measure is ductus venous flow in the heart. Fourth thing we measure is the tricuspid. We see whether there is a tricuspid regurgitation or not. These are the 4 things we look. Along with that, we do the PIH screening, that is pregnancy-induced hypertension screening. So in normal nuchal scan report, you should be seen all these 4 things. Nasal bone seen or not, DV flow is normal or not, nuchal thickness is normal or not, there is no tricuspid regurgitation, and just see whether the radiologist has looked for the uterine arteries, because uterine artery pulmonary index is the diagnostic, higher pulmonary index is diagnostic for pregnancy-induced hypertension. So in early stage, you can detect PIH, that too at 11 to 14 weeks. So you can start your echosprin and see, and so many cases, it just get stopped. You know, there is no pregnancy-induced hypertension we have seen when the patient start echosprin in early stage. So here I am trying to show you, this is the normal nuchal thickness and this is the abnormal nuchal thickness. You can see this is the normal one and this nuchal thickness is markedly increased. So this baby is more chance of having abnormality. The same time we do the double marker test and all. We always mention in our report CRL is this much corresponding to this week. So how we measure CRL? CRL is nothing but the crown rump length. Okay, that is the CRL. Because in our so many reports you must be saying CRL measures this much corresponding to this much. So that's why I kept this slide here to show you all how we measure the CRL. So now that was about the nuchal scan between 11 and 14 week scan. Now we move to the anomaly scan. What we look in anomaly scan? We look from brain to face to chest to heart to abdomen. In abdomen we look for whether the stomach bubble is seen or not. If stomach is not seen, then there can be chances of esophageal atresia. Okay, and if there is a double bubble in the stomach, that means there is a chances of duodenum. Yeah, these are all things we see on anomaly scan. After that, we see the kidneys, whether there is these kidneys are normal or these kidneys are hydronephrotic. After that, we see the urinary bladder. Then we move on to the extremities. Then we move to the spine. So these all I will show the possible common abnormalities in my presentation. Okay, so this is how the normal brain looks on antenatal sonography at 18 to 20 weeks. So these are intracranial structure. This is the cerebellum. So any cerebellum hypoplasia we can rule out at 18 to 20 weeks. These are the thalami. Then you can see the ventricles. So if there is any hydrocephalus, we can make out at 18 to 20 weeks scan. See this ventricle. This ventricle is dilated. And this is the case of ventriculomegaly. That is 18 to 20 weeks scan. You know, we can pick up before at 5th month sonography, this ventriculomegaly. Now I'm showing you some spinal abnormalities. So this is how the normal spine look like. See, from thoracic spine to the sacrum. Okay, these are the normal spine. But here in this image, you can see there is a myelomeningocele. Sorry. Okay. Oh, sorry. So here you can see this black hypoechoic mass lesion sitting at the end of the spine, and that is nothing but the myelomeningocele. See, here you can see the spina bifida. Normally, the spine looks like they're more close, and there is one element spinous process here. Ramna here. Here you are seeing the spine are bifid. See, the both spines are both the elements are far away from each other. So this is spina bifida, and this is how myelomeningocele looks like. 1 minute, please. Battery on. So now here, this is the leg, how it looks normally. Okay, so this is the femur, these are the tibia fibula, and this is the foot. And in this X-ray, you can see the club foot. So the club foot is inverted inside. So this can be picked up in anomaly scan as well. So this is normal leg foot relation you can see, and this is the club foot. See, this is the inward rotation of the foot here, and this very beautifully seen on the 4D ultrasound. Hope you all can see it nicely, and can my voice is audible to you all?
Very clear.
My voice. Okay. So this is the club foot I'm showing you all. So the next abnormality is, let's move to the kidney abnormalities. So normally the kidneys looks like this. This is the spine. These are the paraspinous muscles, and this is the one kidney. This is the another kidney. See the kidney. Okay, this is between 18 and 20 weeks scan I'm talking about. And here you can see some small of a hydronephrosis in the kidney, and this renal pelvis is dilated. So that is a case of a PUJ obstruction, and this we have diagnosed at 18 to 20 weeks of time. This is a urinary bladder, okay, and urinary bladder, this is the posterior urethra which is dilated. So antenatally, this is, we call it the keyhole appearance, okay, yeah. So here, this is the case of posterior urethral wall, in which we see the dilatation of a posterior urethra, and this one abnormality is always associated with male fetus. Okay, after the kidney abnormality, I'm moving to the facial abnormalities. Okay, so you can see this is the 4D of the 4D picture of the face, and see these are the lips very clearly seen. This is the nose, these are the eyes. Here, what is the abnormality? You can see the cleft lip. So this is very nicely seen on 4D. So as and when we do 4D, whenever we see some abnormality on our 2D image. After that, we move on to the heart. I will not go much details, just to show you all how heart looks on sonography. So this is nicely seen 4-chamber view of the heart. Okay, and here you can see there is a defect in the interventricular septum. This is the defect. Sorry, this is the septum here, and this is a case of VSD. See, this is the 4th chamber of the heart. This is the defect in the septum. This is the defect. This is the aorta actually, and this is a tiny 1 to 2 millimeter of VSD diagnosed on sonography. And for such cases, we advise fetal echo at 25 weeks. That will be more clearly seen, along associated abnormalities will be clearly seen. So whenever we see any abnormality, we definitely ask for a fetal echo. Though we don't see abnormality in anomaly scan, still we recommend you get done a fetal echo in high risk patient. What is high risk patient? Age more than 30 years of more than 30. If previous child having a congenital abnormality, if it's a contiguous marriage, that means a marriage in a close family relations, always ask for a fetal echo. So after this obstetric pregnancy sonography, let's move to the musculoskeletal sonography. So what is musculoskeletal ultrasound? Musculoskeletal sonography is the study of tendons, ligaments, muscles, nerves, and joints. The common indication in musculoskeletal ultrasound is the shoulder sonography. Any sports injury, okay, tendo-Achilles injuries, quadriceps injuries, rotator cuff injuries. Apart from that, carpal tunnel syndrome, ganglion cyst, then the bursitis. Most common is that housemaid's knee, where you see the knee joint swelling, tennis leg deformity, then tennis elbow. I will come one by one. So in this, as I said, the most common indication is the rotator cuff injury. Here I'm trying to show you the normal supraspinatus tendon, how it looks like on sonography. So this is the greater tuberosity, this is the lateral tuberosity, and the supraspinatus tendon inserts on this greater tuberosity. Here you are seeing the major tear here in the supraspinatus. You can see this black thing, hematoma. These tendon fibers are separated from each other, widely separated from each other. And that is the case of complete tear of supraspinatus tendon. You know, you always ask for MRI for shoulder patients, shoulder pain and all. Sonography, I will say here, sonography is more higher resolution than the MRI. And dynamic evaluation. Dynamic means when you can do sonography while the shoulder joint is moving. That is the biggest advantage of sonography. Yeah, it has limitation in labral tears. The only thing, if you are suspecting labral tears, then only ask for MRI, otherwise ask for sonography. This is the another case of subscapularis tendon tear. This is the subscapularis muscle. This is the tendon. It normally inserts on the lesser tuberosity. Here you can see the wide gap with a hematoma. So that is subscapularis tendon tear. Yeah, this is an interesting case. This is an old man and came with sudden lump on his biceps. He gave history that he had lifted a bucket of water and heard a very quacky noise, and then this sort of a lump he noticed on his biceps. So that we said is a Popeye sign. And here, this is the biceps tendon tear, rupture of the biceps tendon. This is the biceps tendon, and this is the hematoma fluid, the black color things you can see here. So this is the bicep tendon tear. So whenever you get such cases, ask for sonography. Sonography is a problem solving, immediate results, you know, but one thing, it's operator dependent. Those who trained for musculoskeletal ultrasound can only do these things. Another common am I audible?
Yes, very much.
Yeah, okay. So the decurving stenocytes, usually the patient comes with pain on the radial aspect of the wrist joint. You know, always they complain of pain on the radial aspect of the wrist joint. And most of the time you ask for X-ray, and X-ray is normal. But then what is the reason? Always ask for a sonography if there is no history of injury. Here you can see very nicely the tendon of the first extensor compartment of the wrist joint. And this is the synovial thickening, you see, and lot of hyperemia on color Doppler. That is the diagnostic of decurvent stenosynovitis. This is the picture showing these two tendons are there, which inserts on the thumb. And whenever there is a tenosynovitis, you get pain on the radial aspect of the wrist. Then the commonly seen carpal tunnel syndromes in clinical practice. Patient usually get pain in the first 3.5 fingers, pain and numbness most of the time. And here I'm trying to show you how the median nerve looks like on sonography. See, this one is the normal, and this is the normal median nerve. Okay, we say is a honeycomb appearance of the nerve we see on the sonography. Here you can see that loss of honeycomb appearance and this nerve is enlarged. Here I'm trying to show you this better. This is the transverse section of the nerve. This is the long section of the nerve. And here you can see the notch here. Okay, so here's the compression in the nerve. And you can see post compression, there's increased thickness of the nerve. So we can diagnose carpal tunnel disease on ultrasound. This is how we measure median nerve at different level. Then sonography sonography has a major role in inflammatory arthritis. In rheumatoid arthritis, this is the tool to diagnose. Then in case of prognosis also, it has a very much role when the patient is on medication to see the disease progress or not. Rheumatologists always ask for this sonographies. In rheumatoid arthritis, you see this, you see the erosions of the bones, you see the tenosynovitis of the tendons, you can see here the lot of hyperemia. So these are all the images of rheumatoid arthritis diagnosed on ultrasound. Now the sports injury quadriceps tendon. This is how the normal quadriceps tendon looks like. This is how you guys clinicians do the testing of quadriceps tendon integrity. And this is the normal quadriceps tendon which insert over the patella. Okay, so here is the patella. This is the normal quadriceps tendon. And here you can see this is the patella, this is the tendon insertion, and this is the big gap in the tendon continuity. So this is the quadriceps tendon tear diagnosed on sonography. Oh yeah, this is housemaid's knee. Here, this is very commonly you see in your clinical practice. Usually those who do your housemaids, they do regular mopping and all, and they get a continuous rubbing of their knee to the floor, and then they develop the swelling over the knee, which is very well seen on sonography. Okay, so this is housemaid's knee. Here you can see the fluid in the bursa. Okay, this is the prepatellar bursal effusion that is called as a housemaid's knee. Yeah, this is the, sorry, this is tennis leg. You know what is tennis leg? Tennis leg is nothing but injury to the gastrocnemius muscle. This is your muscle. There can be the injury to your calf muscle, that is gastrocnemius. It can be at the origin of the calf muscle. It can be the bulk at the gastrocnemius muscle. And this is how it looks on sonography. This is normal gastrocnemius muscle, and this is the fluid here. This is the break here. Okay, so this is the tennis leg, can be diagnosed on sonography. Clinically, it is very much typical. Patient just feel the pop-up sound suddenly whenever patient walk or run, or when they try to catch the bus or a train, and then the leg gets swelling. Okay, now this is the next is the tendoachilles tendon. Tendoachilles tendon is the beautifully seen on sonography. This is how we do the sonography of tendoachilles tendon. Here you can see very nicely the tendon is completely broken. Okay, it was basically the injury by some machine plate, and you can see this tendon is broken here. Here also, this is the complete tear of a tendoachilles tendon. See, the tendon is here. It is 68 centimeter. This is the calcaneum where this tendoachilles insert. You can see the normal tendoachilles, normal, and the break here. Okay, so we can give information to the surgeon how much above the tendon is broken. In this case, it is 8 centimeter from the calcaneum where the tendon is broken. Now, this is the very interesting case. This is the importance of the dynamic evaluation. This guy, he was complaining, normally there is no swelling, but when he run or when he sit in a squatting position, there is a bulge on his lateral aspect of a leg. And on sonography, what we can see when we are asking, we ask patient to just sit in a squatting position, and here we have seen this muscle is herniating. See, this is the fascia of the muscle, and from here these muscle fibers, they are just herniating from this fascia. See, when he do more squatting, then you can see the bulge here. So that is the importance of dynamic evaluation, and it is possible in sonography. In MRI, you cannot do the dynamic evaluation. It is a static evaluation. You have to do the scan in one position only. And another importance of what you can say, the merit of sonography over MRI is that you can always compare both the side. So, because so many times there are anatomical variations which can mimic as an abnormality. So we always compare one side with the another side on sonography. Yes, foreign bodies are very beautifully seen on sonography. See, this is the foreign body in the leg. It was a wooden foreign body. The surgeon removed it. It was a wooden foreign body. On X-ray, you cannot see wooden foreign bodies. It is most of the time the metallic foreign bodies only picked up on X-rays. Plastic foreign bodies, wooden foreign bodies are very well seen on ultrasound. So this thorn piercing, then any glass injuries, you always ask for a sonography, because on X-rays you may not see anything. Yeah, this is the beauty of ultrasound. This 7-year boy was limping and pain, continuously crying, and history was very short, 2 to 4 days. Then the pediatrician asked for sonography, and luckily what we can see here is the distension. Here you can see this is the femur, this is the left side asymptomatic, and here you can see hypoechoic collection and synovial thickening. So this is the transient synovitis of the hip joint, very well picked up on a ultrasound. So these are about the musculoskeletal ultrasound. Very few slides has left. Dr. John, just 5 to 10 minutes.
Yes, you can continue.
Okay, thank you. So now this image I am showing you about the color Doppler. So how DVT looks like, because in this COVID area, when there is a positive D-dimer test, there is a more chances of thrombosis, and patient comes to you with leg swelling. Always think of a DVT first. And how we do the color Doppler test, just like a sonography, we see the image like this. This is the femoral artery, this is the femoral vein. Basically, this is the superficial femoral vein, this is profunda femoris vein. So this femoral vein has a thrombus in it. So we are not seeing any color in this femoral vein. So our diagnosis is deep vein thrombosis. This profunda femoris vein is patent. So we are seeing color here. We are seeing color in the femoral artery, and there is a thrombus in the femoral vein. That is the end of my talk. Thank you very much for your patience listening. Hope it is useful to you all, and thank you very much. Over to you, Dr. John.
A wonderful presentation, Dr. Rahul Saoji. I request the participants to kindly keep muted. Yes. So we request the guest of honor to say a few words about Dr. Rahul's presentation. Dr. Rahul, can you close the share screen? You finished your screen, right?
Yes.
Yeah, you can close the share screen so everyone will be visible. Yeah, that's it. Thank you so much. So I request.
Yeah, Dr. Nidhi.
Yeah, I request Dr. Nidhi. Yeah, please share your opinion about.
It was wonderful, very concise, and I liked the flow of where you touched upon the practical aspects instead of making it elaborate. The practical aspects that we need to see in the clinic, follow the patients up, and know an overall idea about what all modalities are there at your disposal, which can be used judiciously for the patient care. Wonderful talk, Rahul. Enjoyed it thoroughly. I always say, when you speak, I always carry home some messages. Thank you. I did that today as well. It was wonderful. Wonderful.
Thank you, Dr. Nidhi Bhatnagar. It was so kind of you. I request Dr. Deepak Patkar to say a few words about Dr. Rahul Saoji and anything he wants to share about radiology. Sir, you can unmute. Dr. Rahul, Dr. Deepak Patkar is there.
I'm not seeing sirs on the screen.
Okay,
Sir.
we can request Dr. Roli is around. Dr. Roli Chaudhary, she can unmute video and audio both.
We'll take participants' questions, sir. That will be
Yeah, I
more
will
helpful.
take the questions. Yeah, but it would have been nice that if Dr. Ratnapaki sir is around.
Sir has a different meeting the same time.
All right, fine. So now we will take the question answer. I request Dr. Nisha Shah to help me. Dr. Nisha, are you there? Okay.
Yes, sir.
Can you take up some questions for Dr. Rahul?
Yeah, sir.
Dr. Nisha will help you, Dr. Rahul.
Okay.
There was one question.
Dr. Rahul
from
can
Dr.
unmute your
Vijay
video.
Gandhi.
Yeah.
They should be able to see you.
Importance of different sonography probes for different tissues. Can you please explain?
Definitely. See, we have a different type of sonography probes. We usually call it megahertz. The power of a probe. So normal probe, when we do the abdominal sonography, it's 4 to 6 megahertz probe. And normally the musculoskeletal ultrasound we do with higher frequency probe. Even like a thyroid sonography, then the testicular sonography, we do with high frequency probes. And the frequency is around 10 to 15 megahertz. The probes in my clinic, I have 7 probes. One is 4 to 6 megahertz, one is 6 to 8 megahertz, one is 8 to 11 megahertz, one is 15 megahertz probe, and one is it is around 18 megahertz probe. That we use for this finger sonographies. That is called hockey stick probe. So if one has the knowledge but don't have a correct probe, he may not able to do the justice with the case. But even if you have the frequency of around 10 to 12 megahertz, you can do all the sonographies. That is what I can say.
Thank you, Dr. Rahul. Another question is in ANC, which USG important for patient with money constraints?
See, money constraint is not like every sonography has a different importance. But one should not, one should not miss nuchal scan. That is a very, very important scan, for Down syndrome screening, for screening of aneuploidy. So that is the must scan. And second scan is the anomaly scan. These 2 scans are the must scan. But I will say you cannot say money constraint. Here, at least because if you miss the first scan of 8 weeks and it's ectopic pregnancy, patient may land up ectopic. And it's the same way if the patient don't do 7 months and if it is a IUGR, then patient may land up into IUFD. So, but still I will say nuchal scan and anomaly scan should not be missed.
Right, sir. Another question is at what interval shall we repeat the CT scan in COVID patients?
You should not repeat CT scan in COVID patient. If the patient is improving, it has to be clinical. We recommend repeat the CT scan. If the patient is improving, then repeat the CT scan after a gap of 8 weeks. If patient is deteriorating, then in that setup, you can repeat the scan as and when required in a clinical setting, in a clinical presentation.
Right, sir. Another question is, can you please throw some light on the findings of COVID patient on chest X-ray? Also, is it advisable to go for abdominal scans?
Abdominal CT scan or a sonography, you mean to say?
I would request Dr. Ripudaman to please unmute and ask your question, please.
Then you can take the next question.
Right, sir.
Hello, Rahul sir. Good evening.
Good evening, Kiran.
Rahul sir, in the village area, we can differentiate the COVID lungs and the pneumonia from the X-ray.
See, that's what I told you. In mild COVID, X-ray will be normal. But when it is a COVID pneumonia, you go in a moderate cases. So in a village, if there is no CT scan or CT scan is not affordable, if you remove X-ray and if you see the only patch of consolidation which is limited to the one lobe and there is no other peripheral opacities on chest X-ray, you can say it can be the community acquired pneumonia rather than a COVID pneumonia. Because in COVID pneumonia, along with a pneumonic patch, there will be a lot of congestion in the chest. Because once it reaches to the pneumonia, there has to be other findings associated on the chest X-ray. That can be the increased vascular markings, sometimes pleural effusions, peripheral haziness in the lungs. So in moderate cases, yes, you can sometimes differentiate, but I will say gold standard is CT scan.
Okay, thank you, sir. Thank you very much.
Another question is, in case of acute abdominal pain, what all investigations should be advised?
In acute abdominal pain, I will say first you have to see clinically, do you think, is there any gardening, rigidity of the abdomen? Is there any urinary complaints? If the patient has come with history of a fever, then again the question is how many days, if the patient is male or female, because sometimes, pain in abdomen can be because of the acute salpingitis, ovarian torsion. Then accordingly, first must investigation is the sonography. Along with that, abdomen standing X-ray, as I showed you. If there is a gardening and rigidity on the abdomen, then you have to think of a perforation that can be missed on sonography sometimes. So you have to take for abdomen standing X-ray. And we have seen a pneumonia in the chest, consolidation in the chest can mimic as abdominal pain. So we say chest X-ray is a mirror of a body. So if your sonography is normal, if your abdomen standing is normal, we have to remove chest X-ray to look for the consolidation.
Right, sir. Another one is, can ACL injuries of the knee joint be picked up by sonography?
Sonography has a limitation in ACL and PCL injuries, but yes, if it is a partial tear, sometimes you can pick it up, but the MRI is the gold standard.
What should be the measurement of knuckle thickness, sir?
See, it has, we have a normograms as per the gestational age, but as per the gestational age of 11 weeks, the normogram is different. To 11 weeks, 3 days, the normogram is different. So we have a software in our machine. We see whether the measurement falls into the normal measurement. But in obvious, we can say at 13 weeks, 6 days, it should not be more than 3 millimeters.
Right, sir. Another question is regarding explaining rheumatoid arthritis sonography in detail. I don't know whether you will be able to do it now.
Rheumatoid arthritis sonography, first of all, we should have, it's very much informative when there is when the disease is in silent stage. That time we can see the bony erosion on sonography, we can see the hyperemia on sonography, we can see the synovitis, we can grade the synovitis. But it is, sometimes it's a serial sonography, then only we can comment on the prognosis of the disease.
In X-ray, can we differentiate between different types of pneumothorax?
Different types of pneumothorax, that means that tension pneumothorax and this thing you're talking about.
Yeah, possibly. Dr. Shwetangi, can you please elaborate on your question?
Good evening, sir. This is Dr. Shwetangi. I wanted to ask about what are the different X-ray observations in tension pneumothorax and a spontaneous pneumothorax?
Okay, see again I will say the pneumothorax, once we diagnose, then tension pneumothorax and spontaneous pneumothorax. The spontaneous pneumothorax can be because of the rupture of the bulla, can be because of the rib fracture, you know, or it can be sometimes during the pleural effusion when it is iatrogenic, you meant to say, during the pleural tapping, the pneumothorax develops. You know, tension pneumothorax is more of a clinical diagnosis than an X-ray diagnosis. That's what I will say.
Okay, sir. Thank you. Thank you very much.
When to decide for CT abdomen, sonography, MRI in abdominal complaints?
See, sonography is the primary investigation, first investigation in abdominal pain. When you see there is a pancreatic inflammation, in that case, sonography, CT scan is more, diagnostic, more informative than sonography, because pancreatic abnormalities, CT scan is the mode of choice. If you ask for a sonography, if you ask CT scan first, and if there is a gallbladder abnormality, then you may miss it on CT scan sometimes, because gallbladder can't be seen well on CT scan. For gallbladder pathologies, sonography is the modality of choice. So this is all hand in hand it goes, you know. Like in pelvic diseases, we do MRI than the CT scan. So first go ask your patient to get done a sonography, and after sonography, let radiologists decide whether the cross-sectional imaging is required or not.
Right, sir. When should a CT microscopic be asked for?
CT microscopic, I'm not getting it.
Dr. Shubha, can you please elaborate your question?
Not CT, USG microscopic, ultrasound microscopic, sorry.
Ultrasound microscopy, you mean to say endosonography for this esophagus and all?
Not esophagus, there's a case of bleeding while urinating. And so I wanted an ultrasound microscopic done. So
there's no ultrasound microscopy as such, madam.
To see the renal damage, if at all.
No, see what renal damage means, how we diagnose a medical renal disease on sonography is that depending upon the cortical ecotexture of the kidney, then the thickness of the cortex. So in case of hydronephrotic kidneys, if the cortical thickness is, you know, its thickness is less, then we say that kidney is damaging. Then we have to, it's not like microscopic something.
Okay.
Yeah.
Thank you, Dr. Rao.
Yeah.
Another question is when to advise for 4D ultrasonography.
4D ultrasound, yeah. So advise 4D ultrasound whenever you have the patient's history saying the previous child had a cleft lip, or it's a high risk pregnancy. Otherwise, we see almost all the anomalies on our 2D routine 2D. Sometimes we need to take help of 4D in obstetric sonography to rule out the cleft lip, cleft palate. That is best seen. Sometimes about the finger abnormalities, clenched fist. But that is radiologist's decision when to switch on to the 4D. Most of the time we get referral because patient want to see baby's face in a 4D, baby's hand in a 4D. That is more of a cosmetic value. But as such, there is no specific indication for a referring doctor to send for a 4D. That is the radiologist's decision when to switch on to the 4D.
Right, sir. Any finding on post-COVID patient on X-ray if the cough is persisting after COVID is negative?
We are getting such X-rays nowadays, and we are seeing this non-specific inflammatory changes in lung that we mention in our regular X-ray reporting, that we see increased bronchovascular markings, and we are seeing pleural thickenings, and because of that pleural pain patient faces. These are the findings we see nowadays on chest X-ray post-COVID, sorry.
Thank you, Dr. Rahul, for patiently answering all the questions.
Okay.
Over to you, John, sir.
Thank you so much, Dr. Nisha, for patiently taking each participant's question so well. And a very big thank you to Dr. Rahul Saoji. I think you have answered each and every question so meticulously. That's what he's very popular for. He hope, and we all enjoyed, all the participants definitely had a wonderful time. They have thanked you a lot. I can see that in the chat box. If Dr. Rahul can take one or two more questions, or you wind up. That depends on.
No problem. No problem. I don't have.
So we request all the participants to kindly unmute your video, and let Dr. Rahul see all the participants on the screen.
Yeah, that will be so nice to see all of
We
you.
had, and a big clap to Dr. Rahul. You are Tendulkar today, full 100 runs throughout. You are plus 100 plus. So extremely well. We have Dr. Nidhi here. We have our guest of honor around. Dr. Nidhi is there.
Congratulations, Dr. Rahul.
Thank you. Thank you. Thank you so much.
So we have 10 minutes more. So if any participant wants to ask, can unmute and ask Dr. Rahul. And we have Dr. Rahul, we have the guest of honor around, or he's left?
Left.
Dr. John, I just have one query. In so many times, we are getting confused about when to advise MRI and CT in abdomen or in the brain. So,
see, madam,
can you just give us a general guidelines?
Dr. Rahul, we can even take help of Dr. Nidhi and your other colleagues. So I think Dr. Nidhi can answer this question if you are kind enough to do it. Yes, Dr. Nidhi.
Muted.
No, I unmuted her. Doctor, yeah, we can hear you. Yeah, you understood the question, Dr. Nidhi?
No, I didn't hear. I was waiting for Rahul to answer. I'm sure he being
Rahul will be there to answer, but I think he needs a break for 5 minutes. He has spoken well, I think almost 2 hours now, non-stop.
Oh, then you don't know Rahul like I do. Rahul, would you like to go on?
Yes, okay. See, I will say, you asked when to ask for MRI brain or a CT brain. So I will tell you, whenever your patient has got a faint, or he has developed some hemiparesis or a plagia, always you have to we have to differentiate between the infarct and hemorrhage. So early infarct can be picked up well on MRI diffusion study. So ask for a MRI diffusion study rather than asking CT scan, because CT scan will not show infarct in first 8 hours of time. That is a golden period for the for the patient. So your CT brain may be normal, but patient has might have developed infarct. So always ask MRI diffusion whenever you're thinking of investigation in a neurological case. And MRI, as I said, a pain in abdomen, first ask for your clinical judgment is very much important. As I said, you can ask for sonography, you can ask for abdomen standing X-ray, even with a chest X-ray. If you are thinking the patient is having fever, if you're thinking patient can have a consultation in the chest. So for the guideline, pain in abdomen, I will say, do ask for a sonography, give liberty to the radiologist to add on the another investigations like abdomen X-ray, standing. And for a neurological case, ask for a diffusion weighted MRI first to diagnose infarct. And if you say in a case of shoulder pain, I will ask you to ask for a sonography first.
I think Dr. Rahul's Wi-Fi has gone a little weaker.
With your permission, Rahul, may I please add a few more things?
Please, madam.
The first thing is, there was a lady who asked a question on pneumothorax. So Dr. Rahul said very aptly, is the lady still there? I hope I can, if she's here, I'd like to address this question.
I'm here. Yes, ma'am.
You're here? Hi, Shwetangi. So you asked a very lovely question. So we have a simple pneumothorax, which we can call as a spontaneous, and then we have a tension pneumothorax. Dr. Rahul said very rightly, pneumothorax, most importantly, is a clinical diagnosis. In tension pneumothorax, it's even a bigger diagnosis because the patient is disproportionately dyspneic. And when you take that X-ray, you see that there is a mediastinal shift because pressure that keeps building instead of a normal simple pneumothorax where there can be a subcutaneous leak also. So subcutaneous emphysema you have. So the entire mediastinum now starts getting shifted and the venous return stops. As a result of this, the patient goes into a severe dyspnea and a cardiopulmonary emergency. So that's about tension pneumothorax, that if we see a mediastinum shifted to the other side, despite no rotation of the patient on an X-ray PA view, we say that this is a tension pneumothorax and practically an emergency. I do hope I have answered that question.
Yes, ma'am. Main concern was this mediastinal shift, actually.
Absolutely.
Thank you very much, ma'am.
An enlarged mediastinal shift, very low diaphragm, hypertransgradient, but you just have to look at the patient's face and you know it's tension pneumothorax. Then I'm going to come back to the next question. Between CT and MRI, whichever way, whenever the patient presents, the first rule is that if it's an emergency, whatever part, whether the head, neck, abdomen, if it's an emergency, please get a CT scan done. I am not talking here of musculoskeletal because MRI usually takes long time, and MRI, the patient may not be able to take it. So if it's an emergency, get a CT scan done. You can get it repeated again. So emergency is a very important factor. And then of course, as Dr. Rahul said, that infarct sometimes can be delayed. But if it's a hemorrhage, you will be able to see it on a CT scan, and then you can repeat along the clinical. The third thing that Rahul said very well, and I think I'm just reiterating what Dr. Rahul said, no investigation is complete without a basic X-ray. I think every clinician must offer the first important diagnostic modality that should be never ignore an X-ray, a plain X-ray of that part, whether it's the abdomen, whether it's the shoulder, not the skull. No, we don't need an X-ray there, thank you, unless there is a trauma. Otherwise, we always say the first step is a plain X-ray of that part, which helps us to build the diagnostic confidence when we go to more superior modalities. So that part is absolutely a must.
Yeah, Dr. Nidhi, there is a question given by Dr. Deepa Parab. When do you advise for a contrast?
That's a very cool question. Somebody talked about abdomen, right? We were talking about abdomen, and Dr. Rahul said we must have an X-ray abdomen. And then he said, yes, we can have an MRI or a CT scan depending upon. But in abdomen, we usually prefer a CT scan because we give contrast, which can delineate the intestines. Otherwise, in MRI, there could always be a point of contention where we are worried whether this is a collection or because there is no delineation. Yes, of course, T1, T2, we have a delineation. So contrast is sometimes always, if there is a mass lesion, if we are suspecting any kind of mass, whether be it benign or malignant, there is no way of differentiating unless we give contrast and we can show that there is an enhancement. That part gives us the clue. So whenever we suspect a mass anywhere in the body, contrast is a must. Then if you are suspecting any vascular insult, we do want, if you're suspecting aneurysms, you're expecting some sort of a vascular trauma, we like to do a contrast study.
Thank you so much.
MRI as well as CT.
Thank you, Dr. Nidhi, so much.
Thank you so much,
Over to you, Dr. Rahul. Anything is there remaining? Any questions, or we wind up the session today? It's been a very long session for almost 2 hours. Thanks, Dr. Nidhi, for spending so much time. And we have the other guest of honor there, or we wind up for the day.
I think wind up.
Yeah. Thank you so much, Dr. Rahul Saoji. It was wonderful. Dr. Nidhi and all the participants, the guest of honor, Dr. Deepak.
Has been amazing. Thank you.
Thanks. Keep safe. Take care, and till we meet again. Bye bye for tonight.
Thank you. Thank you all. Thank you all.
Thank you.
We'll wind up for the day. Bye bye.